This is their virtual background, and as a member of the board of International Society of Pediatric Dermatology, which is the main sponsor apart from British Society of Pediatric Dermatology, BSPD and ISPD combined together, they are hosting this World Congress of Pediatric Dermatology. So I have been requested by Professor Amy Peller, not only me, all the board members, that wherever you appear on virtual, you please use it as a virtual background. So that's why I'm using it as a virtual background, just to promote World Congress of Pediatric Dermatology. So all of you can register yourself. Registration is free. Virtual registration is free for all the 4 days of WCPD Edinburgh. For the selected sessions also, you can register and you can participate. I think, Somnath, it is time to start. Yes? সোমনাথ তুমি ইয়ে করো, অন এয়ার করে দাও।
Yes, already it is on air.
Okay. So good evening, friends and colleagues, and welcome to today's webinar of Institute of Child Health, Kolkata. Over last 2 years, during this COVID period, we have been having regular webinars of different specialties. I am very happy and proud to say here for our, particularly dermatologist colleagues and maybe some of the pediatrician colleagues who are not aware, that Institute of Child Health is the first teaching hospital of India. I repeat, Institute of Child Health, Kolkata is the first teaching pediatric hospital of in India, which was established way back in 1957. We have almost all the subspecialties of pediatrics here: pediatric medicine, pediatric intensive care unit, pediatric rheumatology, pediatric gastroenterology, pediatric pulmonology, pediatric hemato-oncology, pediatric nephrology, everything, in fact, almost. So we are very lucky that whenever there is a critical case, we can discuss among ourselves. These webinars used to be our physical seminars regularly, and from different departments. And from pediatric dermatology, we used to have a seminar almost once in every 2 months. In the pediatric dermatology department, apart from me, we have Dr. Raghubir Banerjee, whom you all know is our dynamic secretary of ISPD. Dr. Rajiv Malakar is the dynamic treasurer of ISPD. Dr. Obhijit Saha and Dr. Nishant Agarwal. So this is our team. We have got a fantastic team. And friends, today we have got a wonderful and erudite faculties for a very up-to-date topic of the day, I must say: skin manifestations of COVID-19 infections in pediatric age group. We have a perfect blend of senior academicians of the country. They are very renowned, pan-India, with junior academicians who are to be watched for next few years because they are the most potential, I believe, and everybody would agree with me. And we have with us the wonderful pediatric critical care expert. So it will be a proud privilege to introduce today's faculties. Is it visible, Somnath?
Yes, yes.
Okay. Dr. Maitri Panda is today's speaker on the topic. She is the professor of IMS and SAM Hospital, Bhubaneswar, with a teaching experience of 12 years. She has 70 publications in national and international journals, of which 14 original articles. She has more than 100 presentations in state and national level conference and CME. She has contributed chapters in textbooks on atopic dermatitis, pediatric dermatology, postgraduate dermatology, IADVL recent advances. She is the editorial board member of IJPD. She is reviewer of IDOJ, IJD, and Journal of European Academy of Dermatovenerology. Her fields of interest are pediatric dermatology, dermatotherapeutics, psoriasis, and psychodermatology. She is National IADVL Academy member during 2018 to 19. She has been the member of the National SIG Pediatric Dermatology Special Interest Group 2020-2021. And she is the office bearer as Joint Secretary of IADVL Odisha State Branch 2015-16 she was, and Vice President of IADVL Odisha in the current year 2020-2021. Welcome, Dr. Moitri, and thank you for joining.
Thank you, sir.
Now we have Dr. Deepika Pandhi, Director, Professor, Department of Dermatology. Before I go to Dr. Deepika, I must say from my personal end about Dr. Moitri, she is very active in our Indian Journal of Pediatric Dermatology and does wonderful reviews and helps me a lot in IJPD work, particularly proofreading and reviewing the articles. Thank you very much, Moitri.
Thank you, sir.
Dr. Deepika Pandhi is the Director, Professor, Department of Dermatology, STD, University College of Medical Science, Delhi. She has 145 publications. She has 20 international and 150 national publications and 35 chapters in various textbooks. She has been the chairperson of IADVL Academy 2020-21 and convener 2018 and 19. She has been the scientific chairperson this year in our national virtual Dermacon. Here I must say Dr. Deepika has revolutionized our IADVL Academy, but by her super dynamic work and thoughtfulness about how this can be taken to the next level, supported by Dr. Deepak Berde, professor from PGI Chandigarh, as her junior. She was awarded IADVL President Appreciation Award in 2017 and 2020. She was awarded a very prestigious Sardarilal Memorial Award for Lifetime Achievement in Dermatology by IADVL Delhi State Branch at QTCon in 2017. She was again awarded the Sardarilal Memorial Award Oration in ASTICon 2017. Her areas of interest are pediatric dermatology, STI, means sexually transmitted infections, connective tissue diseases, autoimmune bullous diseases, and medical education. Welcome, Dr. Deepika, and thank you for joining. Dr. Resam Vasani is a renowned pediatric dermatologist of the next generation. She is extremely dynamic in our ISPD and helps me a lot in IJPD activities for reviews, critical reviews, and for proofreading. She is of great help to me for IJPD activities. She is the Clinical Research Associate at Vijay Wadia Hospital for Children, Mumbai. She was awarded Das Award of Excellence in Dermatology in 2019. Very well recognized award from Delhi. She is the assistant editor of IJDVL, IJPD, IJDD, IADVL Handbook of Pediatric Dermatology. She is the editorial board member of IDOJ. She is the member of SIG Pediatric Dermatology. She was in 2018 and 19. Member of IADVL Academy 2016-2017. Winner of National Amola MD Gold Medal 2009. IADVL Training Fellowship in Dermatopathology. She has 48 national and 9 international publications to her credit, and she has contributed 14 chapters in various textbooks of dermatology. She is the recipient of International Society Munich ISA, famous conference of practical dermatology, then International Congress of Dermatology, which was held in Delhi. She is the mentee under the International Society of Dermatology. Welcome, Dr. Resham, and thank you for joining. Now we have two young persons from two diverse specialties, but very important for today. Dr. Rashmi Agarwal is a consultant pediatric dermatology, Cutis Academy of Science, Bangalore. She has 16 publications, 30 presentations. She has received multiple awards and award papers and e-posters in regional, national, and even international platforms. She is the author and co-author of multiple chapters in dermatology textbooks. She is IADVille GSK National Quiz Program Award winner at the state level. She attended 21st Annual Pediatric Dermatology course at Birmingham Children's Hospital, Birmingham, UK in 2019. Her areas of interest are childhood and adolescent skin and hair disorders, vitiligo, genodermatosis, and dermoscopy. I must say that, Rashmi works with me and we publish papers together, and she has been a great help in, proofreading of my 4th edition of Color Atlas and Synopsis of Pediatric Dermatology, joined with Dr. Sahana Srinivas. Welcome, Rashmi. And
Thank you, sir.
Thank you for joining.
Thank you, sir.
Now we have a very brilliant pediatrician from our own institute, Dr. Prabhas Pashungiri. He is the Associate Professor of Pediatrics and in charge of PICU. He is, star of ICH, I must say. We all depend on him because PICU, is an area of great challenge for the ailing small babies. And his areas of interest are pediatric emergency, obviously, as you can understand, and intensive care infections, critical care ultrasound, pediatric rheumatology. His key published work is that he published more than 50 papers in different peer-reviewed journals and contributed chapters in 5 books. Thank you, Prabhas, for joining and welcome.
Thank you, sir.
On board. And I must say here a big thanks to our director, Professor Dr. Apurva Ghosh, for giving us all the liberty to me and my team in pediatric dermatology to preach and practice pediatric dermatology freely. And we have been doing the best possible work, as far as, possible from our end. And we always, participate in the various, seminars, meetings, publish papers, conduct clinical trials, and various researches in our pediatric dermatology department. And because of his support, several students have, I have been co-guide of the thesis of the several students in the institutes, which is a rare phenomena. As a dermatologist, somebody co-guide of a pediatrician's thesis. I think that because of pediatric dermatology department, our pediatricians in the Institute of Child Health has developed tremendous knack and fascination for pediatric dermatology. And that is all because of support from Dr. Apurva Ghosh, who himself has got great knowledge and keen interest in this subject. Here I must thank today's sponsor, Dr. Reddy's Lab Grandera Division, for not only sponsoring today's webinar and a series of webinars. We will be having 8 webinars. In fact, already we had 4 webinars. But much more than that, over last 10 years, they have been regularly supporting the academic activities of Institute of Child Health. A big thanks to Mr. Devobroto and his entire team of Dr. Reddy's Lab Grandera Division. Thank you, Devobroto, and your team. So with this, we will go to the main, webinar today. And it is my pleasure and privilege to welcome today's speaker, Dr. Moitri Panda to start her deliberation. The platform is yours, Moitri, now.
Thank you so much, sir. Sir, is this full screen appearing properly? Sir, am I audible and my slides are visible?
Yes, ma'am.
Yes, you are audible and your slides are also visible, Moitri.
Yes, yes. Very good evening to all the respected delegates, faculties of ICH, and my co-panelists, Dr. Resham, Dr. Prabhash, Dr. Rashmi Agarwal, and Dr. Deepika Pandhi ma'am, whom I owe a lot. Under her able leadership, I worked in the academy for 2 years, and she was a constant source of guidance and motivation and has given me immense opportunities academically. So thank you, ma'am. And I would extend my heartfelt gratitude, respect, and regards to Sandipan sir for believing in me and giving me this huge platform for deliberation of my talk. I am indeed fortunate to have a mentor like you, sir. So thank you very much for everything. So coming to my presentation today, it is on the cutaneous manifestations of COVID-19 in the pediatric age group. So in the outset, much remains unknown about how COVID-19 affects the pediatric age group. Understanding of COVID-19 in children is still evolving, and their exact incidence and pathophysiological mechanisms are debatable. Accumulating evidences suggest that the mucocutaneous manifestations are extremely polymorphic and transient. Some specific skin manifestations may be indicators of disease severity and prognosis. So before my presentation, we did an extensive literature search. We could find 56 articles on the pediatric COVID mucocutaneous manifestations, and out of which 40 articles were on Kawasaki-like rash and MISC. So one can have an idea how common is the Kawasaki and MISC rash in the pediatric age group. Out of all the systematic reviews and registries and surveys, we found 20 to 25% had mucocutaneous manifestations. The commonest age group affection was 10 to 15 years, with a very slight female preponderance. All manifestations usually resolved in an average of 1 to 10 days, except the MIAC patients, which required hospitalization. So based on the current knowledge on the cutaneous manifestations, going through all the reviews and all the literature, in pediatric COVID, there are 6 main clinical patterns: urticarial rash, confluent erythematous maculopapular morbilliform rash, the papulo-vesicular exanthem, chilblain-like acral pattern, livido reticularis racemosa-like pattern, the purpuric vasculitic pattern, and the multisystem inflammatory syndrome in children, which is the commonest. And this livido reticularis and purpuric vasculitic pattern, it is very uncommon. In fact, very few literature, maybe 1 or 2 literature, which has been published in the pediatric age group. Some miscellaneous cutaneous manifestations include pityriasis rosea, erythema multiforme, erythema elevatum diatyneum, the perifollicular rash, reactivation of herpes simplex infection, which is in fact common both for pediatric as well as adults. Cutaneous small vessel vasculitis has been documented. There is a flare of certain diseases, especially the psoriasis and lichen planus, and erythema nodosum even has been documented in adults. Coming to the oral manifestations, very few literature till date. This literature is from the reviews of medical virology published in 2021, and they have suggested some manifestations like taste impairment, some changes like petechias, ulcers, plague-like lesions, the reactivation of herpes simplex infection, geographic tongue, and desquamatic gingivitis and dry mouth as the chief manifestations in COVID-19 patients. Again, I found another interesting article on International Journal of Infectious Diseases, where they have mentioned the oral signs and symptoms include dysgeusia, petechias, candidiasis, traumatic ulcers, the HSV-1 infection, geographical tongue, the thrush-like ulcers, among other manifestations. And they have mentioned it that these signs and symptoms are highly suggestive of secondary lesions, which have resulted from the deterioration of systemic health or due to the treatment for COVID-19, rather than the primary mucosal involvement. Then doing some search, I found the nail affection. This interesting article published in Journal of European Academy of Dermatology in 2020 has suggested a new sign, that red half moon nail sign, a novel manifestation of coronavirus infection, where you could see the distal half moon shaped surrounding the distal margin of the lunula. And another presentation from dermatology therapy published in 2020, where there are transverse leukonychia or MEES line in COVID-19 patient. Both of these case reports were from the adult patients, not from the pediatric series. There are few other skin diseases which are aggravated by using masks and sanitizers in COVID era. So even it goes for the pediatric and the adolescent age group. The term called mask acne has been introduced recently in this COVID era. This is something in this hot, humid climate with the acne mechanica localized to the chin, cheeks, and around the nose. We do find a lot of adolescent and youngsters presenting to us with mask acne. We have mastenia. This is in fact our own publication in the Journal of Clinical and Experimental Dermatology because of repeated use of mask. Then atopic dermatitis, aggravation of the hand eczema using sanitizers. And also the pre-existing seborrheic dermatitis gets aggravated and the folliculitis appears due to repeated use of mask. Now coming to some very important critical reviews, which after the extensive literature search, there were more than 200 articles, out of which there were some few articles on pediatric age group. And this particular article was by Harjas Singh et al. From USA, and this article suggests that maculopapular rash, chilblain-like rash, urticarial, vesicular, livedoid, and petechial lesions are commonly seen in the pediatric age group, along with the Kawasaki and MISC type of presentation. So this was a large review of almost more than, I think 56 articles were reviewed in this article, and they have this inference. Now coming to another article published in Dermatology, very, very interesting. I could find very easy to understand this article on current knowledge and future perspectives by Genovese et al. And they have elaborated these patterns in a beautiful flowchart, having urticarial rash, confluent erythematous maculopapular morbilliform rash, the papulo-vesicular exanthem, chilblain-like acral pattern, the libido reticularis pattern, and the purpuric vasculitic pattern. So they have put this diagrams, and they have put another very important table where they have studied the large number of population study, which was done in mainly the European and Scandinavian countries, which includes Spain, Germany, Italy, and France. And this unpublished data from the Italian multicentric study, which has been now published, and that has spoken about a papulovesicular exanthem. This was the first study which has spoken about the papulovesicular exanthem, which was originally described as varicella-like lesions. The main clinical features include papulovesicular exanthem, mainly the truncal involvement, scattered distribution, and there was almost mild or absent pruritus, which differentiated it from true varicella. And the skin lesions appeared on an average of 3 days after the systemic symptoms of onset and healed within 8 days without any scarring sequelae. And later they renamed as COVID-19 associated acantholytic rash. So this study was mainly, this type of rash was mainly into the pediatric population. The largest review till date has been published in International Journal of Dermatology by Mirza et al. And here they have taken more than 2,500 patients in this cohort, extensive systematic review. Almost like more than 86 reviews have put in this one particular comprehensive systematic review. And here the pediatric population was about only some 15 patients. And what they found out was the average age for pediatric patients with dermatological manifestations was 12.9 years of age. And the average latency from COVID-19 symptoms to appearance of cutaneous findings was ranged from 3 to 7 days. And all these dermatological manifestations were very benign, transient, and resolved in a few days to few weeks. So these were the, from this systematic review, I could find these were the studies which were published mostly from the European countries, Italy, Spain, France, and few from China, UK. Also, there were studies from one study from India. That was a case report. So all these datas, cumulative all these datas, what was their conclusion was the chilblain and pernio-like lesion was seen in 40% of the cases. The erythematous maculopapular rash was seen in 22% of the pediatric patients, and then followed the vesicular lesions, viral exanthem, and neonatal exanthem. And in their study series, the urticaria, livedoid lesions, petechias, purpuras were mostly seen in adults rather than the pediatric age group, and MIAC was not included in this systematic review. So briefly, I would go through chilblain or pernio. So these are multiple erythrocyanotic lesions involving the acral skin, which rarely becomes ulcerated plaques when it becomes very severe, and it involves the periungual and subungual skin. So the dermoscopic pictures, this was published in JADV in 2020. That includes the red, purple, grayish background with white rosettes and whitish streaks and a reticular network. The pathogenesis includes virus-induced interferon hypothesis, the thrombosis and coagulopathy hypothesis, and the vasculitic hypothesis. So these three pathogenesis were involved for the chilblain and some severe affection of chilblains, that is the COVID toes, the necrotic acral lesions, and this usually affects the younger patients. Sometimes it may be very severe and associated with higher mortality, but usually it has a very less severe course. It is painful, itchy, patches of erythematous papules, which may range from simple papules to plaques to gangrenous lesions on the toes. And the pathophysiology included the immune dysregulation and mostly the vessel thrombosis, neoangiogenesis, and hypercoagulation state. And lastly, the controversial data on the real association of chilblain with COVID-19. There were multiple school of thoughts, and these published data which were earlier stating that chilblain is a direct association. What happened is they haven't done the SARS-CoV-2 testing in the patients. So there was a question mark whether actually this association is a real association. But in the absence of definitive data, the occurrence of such lesions should prompt confirmatory testing for COVID-19. This is not for Indian patients mostly. This is mostly for the European and American countries. We don't get much of chilblain patients in COVID-19 in India. However, this is the controversial data till date. Now, this is the largest series in pediatric COVID-19 review by Andina et al. And this was published in Clinical and Experimental Dermatology. And in this part one of this systematic review, they have demonstrated chilblain-like lesions, which was repeated worldwide. The learning points in this review was acral ischemic lesions similar to chilblains have been reported worldwide during the COVID-19 outbreak. The lesions were common in adolescent and young adults, and they appear as erythematous violaceous swellings with purpuric macules and vesiculobulous lesions. Prominent vascular damage was the hallmark in COVID-19 chilblains. Outcome was excellent with recovery in almost all cases after 4 to 8 weeks. And the link between COVID-19 and chilblains still remains to be proven, but seems most likely. The second part of this review included the other skin manifestations of COVID-19 in the pediatric age group. And here the learning points were: lesions indistinguishable from EM may occur in association with chilblains. Urticaria occurs in 10 to 20% of the cases. A monomorphic vesicular and a papular vesicular disseminated exanthem has been reported. And the MIAC have a severe course of COVID-19 in children. It resembles the Kawasaki-like disease. And other form of exanthems, which included like purpuric rashes, maculopapular exanthems, pityriasis rosea-like eruptions, and oral findings. So these were the 4 distinct type of cutaneous findings in their systematic review: vesicular rash, urticarial rash, EM type of rash, and the MIAC rash. Another review by Farah et al. From Morocco, and they have published this, they have put forward in their study about the Spanish series, including 20 children and adolescents having acral lesions. They included the acral erythema, dactylitis, purpuric maculopapules, and mixed pattern. So they have also focused on the acral ischemia and chilblain-like lesions. A few data from Indian studies. Very few Indian studies have taken the pediatric COVID into account. This was an article published by Ashish Dalal, Deepak Jhakar, Vishal Agarwal, and Ravi Benewal, and in Dermatology Therapy in 2020. And their main inference was the maculopapular rash, urticaria, pruritus. They could not find other lesions like vesicular eruptions or chilblain-like lesions and vasculitic lesions. Maybe they have seen, their inference was they had seen the mild to moderate cases. So probably for that reason, they have not seen other manifestations. And here the pediatric patients less than 20 years were only 2 patients. One was 17 years and one was 19 years. Other patients were adults in this series. View in Indian Journal of Pediatric Dermatology. And there they have mentioned the first case reported from Italy and also from Spain. And they have mentioned erythema multiforme-like lesions without any history of other viral infections or drug intake or recent immunization. And they have quoted the Journal of Academy of Dermatology, the Blue Journal, of 171 lab-confirmed COVID-19 patients. And they have also the exanthematous morbilliform rash, predominantly involving the trunk, the pernio-like chilblain nacral lesions, and urticaria, macular erythema, vesicular eruptions, and the papillosquamous eruptions. So coming to the other study from South India by Sukhabasi et al. And here the study was undertaken in more than 1,000 patients, out of which the prevalence below 20 years was 3.38%, and there was 10.41% had cutaneous manifestations. Again, the manifestations in pediatric age group were urticaria, vesicular rash, and maculopapular rash associated with pruritus. And this was the review. I am a part of this review in Indian Journal of Dermatology current issue. And also from this review, there's some manifestations like dengue-like lesions, the pityriasis rosea, acroischemia, livedoid lesions, which has been described in literature along with the MISC and Kawasaki-like rash. An article from, and they have put forward whether the skin manifestations in COVID-19 patients are indicators of disease severity and, a systematic review. And what they have informed from their study is the mere occurrence of skin manifestations in COVID-19 patient is not an indicator for disease severity, and it depends highly on the type of cutaneous manifestation. Like chilblain-like lesions has the least severity and the better prognosis, and vasculitic and vascular lesions have a severe prognosis. So the critical disease clinically suggests necrotic vascular, urticarial vasculitis, livedoid reticularis, purpura, and diffuse petechias associated with coagulation defects. And urticarial lesions and maculopapular rash are associated with intermediate severity of COVID-19 disease. So these are the few pictures from that study, which have mentioned the purpuric lesions, the retiform purpura, the petechial lesions, the vasculitic part, everything has been depicted in these pictures. Now coming to the most common manifestation, the multisystem inflammatory syndrome in children, which was first described in UK in late April in 2020. And this inflammatory syndrome has overlapping features of Kawasaki disease and toxic shock syndrome, fever and tachycardia with erythematous polymorphic rash, few differences from the Kawasaki, which I'll be discussing in the later slide. And the molecular mechanism behind MISC cutaneous manifestation is still debated and unidentified. So these are the case definitions for MISC, the CDC United States definition, the UK definition, and the WHO definition. In all the three definitions, what is common is the fever and the severity with multi-system organ involvement, and the COVID-19 infection association in the serological markers like the RT-PCR positive and antigen positive and COVID-19 exposure within 4 weeks before the onset of symptoms. And they have put the exclusion of no other alternative diagnosis before diagnosing MISC. This review article on MISC, which suggests along with fever, abdominal pain and vomiting, the GI symptoms forms a predominant finding in all MISC patients, and the conjunctivitis. So these are the 4 most important things you have to look out for a MISC patient. Even though the cutaneous manifestations may or may not be there, that it forms a lesser importance. But what is more predominant is the fever, abdominal pain, vomiting, and conjunctivitis. And this was published in the Blue Journal on the mucocutaneous manifestations of the hospitalized children. They had taken almost 50 children hospitalized with COVID-19 in 2020. And what they have suggested is children with fever, GI symptoms, respiratory symptoms with RT-PCR positive and IgM ELISA positive. They presented with maculopapular rash, conjunctival hyperemia, red cracked lips, and strawberry tongue. So this were highly suggestive that the patient required the PICU care and the prompt treatment with immunosuppressants, immunomodulators like steroids and IVIG because of the grave prognosis in these patients. Again, a series of almost 35 hospitalized children published in JAMA Dermatology. And they also have mentioned about 83% of the patients exhibiting mucocutaneous symptoms, conjunctival ingestion, palmoplantar erythema, lip hyperemia, periorbital erythema and edema, strawberry tongue, malar erythema, which were the most common findings in the MISA children who were hospitalized. The similarities between the MISA and Kawasaki. So there are few things to be taken into account. Like in MISA, what was the age of presentation was the older children and adolescent, whereas in Kawasaki, it is usually the infant and young children less than 5 years. And here the race and ethnicity, they have mentioned about the Black and African origin and Hispanic origin. And Kawasaki, it's mainly the Asian origin. The most predominant symptoms which was presenting with MISA is the gastrointestinal symptoms, which is commonest in almost about 50 to 90% of the cases, which is very uncommon or less common in Kawasaki disease. The cardiac manifestations, myocardial dysfunction was very common, and organ dysfunction in the form of multi-organ affection was again common with MISA, which was not much common in Kawasaki disease. And coming to the inflammatory markers, here what is important is the thrombocytopenia, which is seen in MISA patient, whereas thrombocytosis is seen in Kawasaki disease. The treatment part almost remains the same, but here the outcome is more fatal in MISA, so the treatment should be given at the earliest possible time. So we need to remember older age group, GI symptoms, cardiac manifestations, mainly patients present with tachycardia and thrombocytopenia. They are the markers of MISA and can help us to differentiate from the Kawasaki disease. Another interesting article published in Lancet. This was an Indian series, Indian case report, which was published from Kochi, Kerala. Dr. Somya Jagadisan was one of the co-author, and they have mentioned this 24-year-old female neonate, which was admitted in the pediatric cardiac intensive unit on the 24th day of life. And the mother had COVID positivity in her last trimester, 31 weeks of gestation. And this child presented with first initially erythema over the occipital region and the buttocks. Gradually, this erythema became more deeper, changed into ulcers with necrotic eschar formation. And they also healed with the healing of with the treatment, proper treatment initiated for MISA. So this was a association of prenatal exposure of SARS-CoV-2 in an infant or in a neonate, which was, I think this is the first publication in a neonate till date. Another series of neonatal multisystem inflammatory syndrome, they have put the term MISN. And this is again an Indian study published from DY Patil Medical College from Maharashtra. And they have summarized that these patients are 20 neonates born to mothers with a history of SARS-CoV-2 infection. Which were exposed, the mother was COVID positive, and these neonates were born to mothers of COVID positivity, and they have presented with MISN. And here skin manifestations were not very predominant, but other things were there to diagnose. The last part will be the post-acute COVID-19 syndrome. This was like how the COVID patients manifested post-recovery. So coming to the dermatological importance, what I found out was hair loss is the predominant symptom, and it was approximately seen in about 20% of the COVID survivors. And the MISA was again the most important manifestation in the pediatric age group. So few of my personal experience in association or collaboration of our department with the Department of Pediatrics in our hospital, we have seen 5 to 6 patients of urticaria presenting prior to COVID-19 diagnosis, during the COVID-19 diagnosis, and post-COVID-19 treatment. These children presented with acute urticaria, chronic urticaria. This patient was a 12-year-old child, a papular vesicular eruptions on the extremities, and presented with fever and this type of lesions. And when we sent the RT-PCR, it came out to be positive. Maculopapular rash, very the mild severity of COVID. It was just a fever of 1 to 2 days, but the child presented to us with severe this type of maculopapular rash. There was no systemic symptom. The child was absolutely healthy, and the rash also subsided within some few days. Kawasaki-like rash. This was a patient admitted in the Department of Pediatrics, and this child presented in a subsiding rash, strawberry tongue, and the periungual desquamation was seen in this patient. And this patient of MIAC was admitted in the PICU. Dr. Vikrant Prushti has forwarded me these pictures from the Department of Pediatrics. And this child, you can see the conjunctival congestion or the hemorrhage. This MIAC child having this rash. The problem is the color, the skin of color. So in our Indian patients, we do not get to appreciate the rash very clearly. And what I got to know is this patient recovered completely with steroids, IV steroids, and immunoglobulin was not needed in this patient. So the pediatricians, they have seen more than 50 patients in this second COVID wave of MIAC. And they have admitted many patients in our institute, in the PICU, and also in the ward. And the patients have good prognosis if it was the treatment was initiated early and treated properly. So to conclude, the pseudo-chilblain and vesicular lesions may be useful as diagnostic indicators of infection among the asymptomatic pediatric patients. Maculopapular lesions and urticarial lesions are the commonest manifestations in pediatric patients in Indian studies. The cutaneous lesions are mostly transient, benign, and requires only symptomatic treatment. MIAC requires hospitalization and prompt management, and a proper registry which will actually help us to collect all the cases and better define the cutaneous manifestations. So before I go to the thank you, my acknowledgements to Dr. Debashri and Dr. Akash, my postgraduate students. I am their guide, and they have immense contribution, and they have helped me to make my presentation. So thank you very much for your patience hearing. And hope is the last thing ever lost. So we hope the third wave of COVID never comes, and all our pediatric and children are safe in our country. Thank you very much.
Thank you so much, Dr. Maitri. It was a wonderful deliberation, an extensive review of literature with photographs. I was literally, very much impressed with your presentation as it was expected. I have attended a couple of lectures on skin manifestations of COVID. I must say that this is the best I have heard so far. So a big tap to you. This is a wonderful, really wonderful deliberation. And so extensively you have covered all the literature, both the Western literature as well as the Indian literature. And let me tell you, friends and colleagues here, that the review article which Dr. Maitri Panda has contributed in the recent issue, current issue of Indian Journal of Dermatology, Asia's oldest journal in dermatology, Indian Journal of Dermatology, which is published from Kolkata. This particular article, when I went to the article journal site, this particular article has got the highest number of hits, so far for this particular issue. So once again, heartiest congratulations for writing such a wonderful article and for this wonderful deliberation. Now, before I go to our esteemed panelist, I must say that this is very interesting to note that you have mentioned it, in your deliberation to a great extent, that it has been found that various manifestations on skin in COVID-19 infections peculiarly, differ in different countries. Now, the reason may be varied depending on the, skin type, ethnicity, COVID-induced pathogenesis, whether coagulopathy is more or whether this is just a macular, skin infection involvement or not. It has been seen that in Italy, maculopapular non-specific rash has been the commonest, which is often confused with drug rash. In China, the cases of COVID, they presented mostly with ischemic rash and arterial lesions. These are hardcore data which I am quoting from different countries. Dengue-like rash mostly been reported from Singapore and Bangkok, cases seen in Singapore and Bangkok. In France, mostly pseudo frostbite and persistent painful redness is seen. COVID toes and COVID heels, those seen all over the world, but in the United States, it has been maximum described. COVID toes and COVID heels, apart from ischemic rash, like pseudo frostbite like rash and vasculopathic rash. So this is something very interesting to see that globally, the skin manifestation of COVID varies a lot in terms of its morphological pattern on skin. We, the dermatologists, always go by the morphology of the skin lesions. So now I would like to come to our esteemed panelists. May I request all our panelists to switch on their camera and microphone. Yes, I can see you. Deepika, your microphone is, yeah. Dr. Deepika, Dr. Resham, Dr. Rashmi, and Dr. Prabhash, you are yet to switch on your camera and microphone both. I shall first come to, Dr. Deepika. I remember Deepika over the last 2 years, because you have been so active in, conducting the various academic activities of IADVL as the chief convener of IADVL Academy. We have discussed and I have come to know that you had to do COVID duties in your hospital as a compulsory duty. So I am sure that you have experienced yourself the kind of COVID cases and the rash. Could you please share with all of us?
So one of the very interesting thing is I was listening to what you were describing. That is the published literature where you have the differences, reported in, the reports vary, like she pointed out, even cutaneous from 0.25 to 25%. So some of it is, of course, in our darker skin, many of the things are not visible. B, we were not looking because we were, especially the second wave, we were overwhelmed because skin was not the priority at that time because the fatality, as we know, was so high. The systemic morbidity was so high. And we all also would agree that the first wave and the second wave, there was a difference in the cutaneous manifestations. So in the second wave, we have specifically seen, I remember there were a lot of dermatologists who said, why we started a COVID registry from IADVL. And they said, why do we need a registry? We do not have any skin manifestation in Indian patients. Not only the type, they said we do not have. But after the second, we've seen, especially post-COVID, a lot of whatever Maitreyi has so beautifully described. We've seen almost the whole spectrum in our patients. So we've seen vesicular, very common. We've seen varioliform. We've seen maculopapular. We've seen a lot of urticarias. We've seen even the nails she described. I like to talk about the nails separately because that is one of our, in our department, everybody knows an area of interest. So we did a study on the nails. And we've seen Kawasaki, like the pediatric inflammatory multisystem syndrome. So we've seen a lot of these varieties, racemosa, like even livedoid. But one thing I can say, we did not see as much as reported was the COVID toes. There is no doubt we did not see as much as Western literature COVID toes, but we did see in older patients livedoid and racemosa-like pattern. The other thing is that we were probably not looking up. And what probably I should add to what Maitreyi said, we also did see a lot of mucor. All of us know that there was a lot of mucor which we can say add to the post-COVID complication of, so our hospital was for 2 months full of mucor, which were including in adolescents and younger pediatric patients also, as well as older patients. Now, talking about nail, I mean, that is very interesting the red half moon sign, actually, it's just a sign of what's happening in the system. So nail is just a manifestation of that it's a systemic, disease, and you have the microhemorrhage and the whole thrombotic, whatever we are describing. So you can see splinter hemorrhages, the red half moon sign, which is like seen parallel to the lunula, again is a manifestation. Then the teres nail and the Mies line are actually because of the systemic involvement, whether it's cardiac involvement or it's liver involvement, because we've seen a lot of systemic morbidity, especially in the second wave. So there were a lot of multi-organ failures and we lost a lot of patients because of that. So the nail is a very simple thing which can predict early that this patient has systemic morbidity. And most of our patients in the second wave had a lot of pro-inflammatory marker. I think even in pediatrics, Dr. Prabhas will agree that the increased procalcitonin, D-dimer, so ferritin increase, this was really very remarkable. And in fact, the ferritin increase has been linked to the mucormycosis. So it has been, I mean, we've seen a lot. So it's only when you look, so we have not published as such because in India this time we got overwhelmed by COVID. So the serial documentation required for research probably may not have occurred at most places, but we have seen. Very interesting from what Maitreyi said was reactivation of herpes. So we've seen a lot of reactivation of herpes as well as of varicella. And when I'm saying all this, zoster, we got so many teleconsultations for zoster, even in adolescent children. That was also very interesting. I don't know if other people have seen that. And the other thing is the same kind of spectrum can be seen post-vaccine. So we got a lot of, post-vaccine similar kind of vesicular lesions very commonly and urticaria. So I think all of us must have got teleconsultations from friends and families in addition to patients for post-vaccine rash. So it's very much there in India. We just have to look for it and document it.
Thank you, Deepika, for your insightful thoughts and a lot of informations which are extremely valuable, I believe, for all of us. And from your first-hand experience, and you have very rightly pointed out and very wonderfully you have phrased all the things. I was particularly impressed by the very saying of yours that for COVID infections, particularly the second wave, after which we became more aware about COVID, and because the first wave did not affect that much or hit that much, and we were all busy setting up our home, managing patients rather than documenting the patients or collecting the data, because our infrastructure is quite different than infrastructure in United States or in the Western countries, Europe. Even with the best possible infrastructure, they were also overwhelmed. And that's why we see, as compared to disease and its severity and the kind of people affected, the data is not forthcoming because everybody was busy in managing cases rather than jotting down the data. Who has got the time to jotting down the data? So that part I really liked. So thank you. I shall come to you again. Now to Resham. Resham, one of the worst hit state in India by COVID is Maharashtra, apart from Kerala and a few other states. And as we all know, in Mumbai, because of COVID, probably one of the longest lockdown continued in Maharashtra, in Mumbai and part of Maharashtra. So, working in Mumbai and being associated with the child hospital of Bijay Wadia's stature, what is your experience of, seeing cases of, COVID infection in children with skin rashes? Over to Resham.
So, in Wadia, we were not involved in the COVID management. The COVID ward was kept very separate. But what we have learned from the pediatric faculty who are managing COVID pediatric patients is that they have found COVID toes to be common. Now, unfortunately, we have never been given a reference for it, but they found it to be common. Urticarial rashes, yes, we have also seen very commonly in the pediatric age group. And in fact, urticaria was the only manifestation of COVID in few patients. The symptoms of URTI, they were on the day 4 or day 5 post the appearance of rash. And in one patient, there was no history of COVID in the family. And it was only because there was an ongoing pandemic and urticaria is one of the known presentations. So the patient was screened for COVID and came out to be positive. So also erythema multiforme is one presentation. Now, whether it was secondary to the reactivation of HSV because of COVID, or was it per se because of COVID, is something not known to me. But that patient had typical erythema multiforme lesions on the palms and the soles. The grandfather was nasopharyngeal PCR positive for COVID. The child was not tested. The child was given acyclovir, responded. So it can be a self-limiting thing with COVID as well. One of the other interesting cases which were seen post-COVID was leukocytoclastic vasculitis. This patient was biopsied, was diagnosed leukocytoclastic vasculitis. HSP was one of the differentials, so was subjected to direct immunofluorescence. It was negative. The patient responded to conservative treatment. Erythema nodosum again was one of the manifestations which was seen. Like these patients were in the wards, not in the COVID wards, but they had history of COVID. So that's why they were shifted to the general ward, and that's how we saw this spectrum. Vesicular rashes, I have not seen per se, but I have definitely seen reactivation of varicella, reactivation of herpes zoster very commonly, and purpuric rashes. One patient has had history of COVID in the family, was not tested COVID. So there was a temporal association with COVID, and that's how we suspected that it is one of the clinical manifestations of COVID.
Thank you, Resham, for your wonderful comments and your personal experience sharing. I shall we'll come back to you again. I shall go to Dr. Prabhas Prashun now. Prabhas, could you just switch on your camera and microphone?
Yes, sir.
Prabhas, you are in charge of, pediatric intensive care unit of, Institute of Child Health, where I am sure that you have seen a lot of cases of COVID. And what type of skin rashes you have seen, and what I would like to know from you personally, particularly, is that the topic which we are discussing, have you seen the severity of COVID has got something to do with some type of rash, or from the pathomechanism of the complications of COVID? I mean, vasculopathy, we are seeing more of ischemic necrosis, something like that, COVID toes, or other types of manifestation, or TN like rash, or chickenpox like rash. So what is your experience? Could you share with all of us?
Firstly, I want to express my sincere thanks to the speakers for the wonderful presentation. Basically, we were able to see two types of COVID patients. One is basically a direct COVID cases like acute COVID-19 infection in children. Another is the post-COVID manifestation, that is called MISC or PIMS. So among the acute COVID-19 cases, fortunately, most of the kids were either asymptomatic or mildly symptomatic, and most of the kids, around more than 99% of kids, was not so severe to take hospital admissions. In this mildly symptomatic or asymptomatic kids, mostly I have seen few of them in the OPD and see via the online consultations. I only encounter a handful of cases that may present with some sorts of measles-like rash, maculopapular rash. Some of them present after the fever subsides, then there may be rash. So they are quite worried that fever subsides, then again the rash started, like exanthum subitum. But that was in a very less number of cases. We are quite fortunate enough to not to deal with a large number of severe acute COVID-19 cases. we have encountered only 8 or 10 cases of severe acute COVID-19 cases that has been admitted in the pediatric intensive care unit and needed some sorts of respiratory support. In all the patients, there was not as such skin manifestations except one. This patient has a patient of SLE with a multi-system involvement, and there was a different types of skin rash. There are some mainly purpuric skin rash, and there are some palpable purpurias were there. There are some macular rashes. No bullous rashes has been seen. There are some necrotic rashes was there. So whether these rashes were the manifestations of complicated acute severe COVID in this patient or the manifestation of SLE complications with secondary APLA or secondary thrombosis was not very clear to us. So we have not seen any other rashes in any other severe acute COVID-19 cases. But the main predominant rashes that we were able to see the MISC patients. Both the first wave and second wave, we encountered more than 160 cases of MISC. In the first wave, we could see around 80 cases of MISC, and second wave is more than 100 cases of MISC. So what we did, we have compiled all the data on MISC, and we can summarize is that we have encountered 4 types of MISC. First type of MISC is an acute MISC that is associated with acute COVID-19 infection with COVID-19 RT-PCR positivity. They mainly presented with respiratory symptoms with fulfilling criteria of MISC. Other 3 cases were RT-PCR negative but COVID-19 antibody positive. They were mainly divided or subclassified in 3 groups. Number 1 is that classic or severe MISC or MISC with multiple organ dysfunctions or MISC or shock. These are the classic MISC. They were almost 50% of all the cases. They typically present with multiple organ dysfunctions, specifically myocarditis, ARDS, shock, AKI, and various other types of manifestations. And we could see lots of types of skin manifestations among them. There were macular rashes, papular rashes, purpuric rashes, vasculitic-like rashes, erythema multiforme-like rashes, tail-like rashes, urticarial rashes were there. In few of them, developed rashes very early. Those who developed very early rashes, they had a good prognosis. And those who developed rashes later on, they have a bad prognosis. Why so? Because those who have developed rashes later on, they got the attention of the medical fraternity later on. Those who have developed rashes on day 1 and day 2 of the fever, the parents went to the pediatricians on day 1 and day 2 and they investigated for the rashes and got a very high CRP and total counts and inflammatory markers. And few of the patients where the rash appeared later on, like a patient presented with a pain abdomen, features were suggestive of acute appendicitis, almost was posted for OT. And the OT, the surgery resident discovered some sorts of rashes in the legs. They almost anesthetized the patient. And they called me and I got in the OT and found out there are some rashes. So initially I thought it to be HSP. Then we took the patient out from the OT, took the patient in the ward, and within next 2 hours, the patient developed severe shock, myocarditis, had to be intubated and ventilated. So those who developed rashes later on got the attention of the medical fraternity later on. So they got a bad prognosis, I think. But as such, we cannot say that rashes has these certain types of prognosis or no rash has good prognosis or bad prognosis like that. Possibly delayed in the medical attention is one of the cause. Another thing is that rashes were quietly very much helped us to assess the responsiveness to immunomodulator therapy. So those who presented with the florid rashes, we have seen that either after starting on IVIG and methylprednisolone, the rashes went out. So if the rashes disappeared very early, that means sometimes we see that after starting IVIG within 1 or 2 hours, the rashes started disappearing. So we are quite confident now, okay, this patient will respond to IVIG and this patient will get out of the ventilator. This patient's cardiac function will improve. So this was very much satisfying to us. So my resident told, sir, after each and every drop of IVIG is going and each and every rash was disappearing. So he or she was counted that each and every drop of IVIG was going and each and every rash was disappearing. So like this, we can prognosticate that if the rash disappears very early, so prognosis is good. And suppose after IVIG and methylprednisolone, the rashes disappeared. Again, the rashes reappeared. So means it is a refractory cases. So we need to step up our immunomodulatory therapy with further doses of IVIG or steroid, even other immunomodulators like tocilizumab or infliximab. So suppose we have given a immunomodulator therapy in a very sick classic type of MISC that presented the multiple organ dysfunctions. Rashes disappeared, patient went well, afebrile for 2 to 3 days, again developed a fever. The cause of fever mainly the recrudescence or reappearance of the disease itself, maybe due to some other causes, maybe due to secondary sepsis because the patient was immunosuppressed staying in the ICU. But if this reappearance of fever is associated with the reappearance of rash, we are quite sure, no, this is not as other causes. These are the causes of recrudescence or reappearance of the disease. We need to intensify the immunomodulator therapy. So these were mainly the importance of rash in our cases. So another thing is that another 2 types of MISC that we got. This is a classic MISC. Another 2 types of MISC. One is the KD-like MISC. These patients were quite similar to Kawasaki disease. They fulfilled all the criteria of Kawasaki disease, everything, plus COVID IgG positive. These patients were KD-like MISC. These were less severe, no myocarditis, mainly coronary involvement, and all types of skin manifestations that can be seen in Kawasaki disease was seen in these patients. Number 3 patients, number 3 type or number 3 phenotype is that we called it mild MISC or febrile inflammatory syndrome. They were tightly fit in the criteria of MISC for COVID IgG positive, but neither fulfilling the criteria of severe MISC like myocarditis or shock, or neither fulfilled the criteria. This patient mainly managed with watchful expectancy or some low doses of steroids. In these patients, we got few of the cases scarlentiform rash. The rash was very prominent with scarlentiform rash. Another thing that we want to mention that most of the MISC patient, be it an acute type or severe type or KD phenotype or mild phenotype, had some sorts of Kawasaki disease-like discommission in the 2nd or 3rd week of illness. And discommission was typically periangual. And few cases, those are typical KD-like presentations, like KD phenotype MISC, had a Buse line in the nails in the 2nd or 3rd week of illness. So these were our experience about, specifically my experience about skin manifestations in COVID-19 patients. One patient presented with tail-like features, but not fulfilling other criteria of MISC, but incidentally came out to be COVID IgG positive. We don't know whether it is an incidental finding or just a causation. We don't know about it. But in acute COVID-19, we have not exposed to too much of skin manifestations.
Thank you very much, Prabhas, for your very useful input from pediatrician's point of view. It is extremely useful for all of us because you handled these cases and you have got wide experience of seeing such cases yourself and managing. What is very important here that what Prabhas mentioned that Buse lines like, and we have been seeing post-COVID, I shall come to this topic soon after this, that what are the post-COVID skin manifestations we are seeing. We can understand that there was temporary arrest of growth of both, nail and hair. We have been seeing hair fall. Buse lines is not something, which is unexpected in such situation. Now the question remains whether these Mies lines and red half nail, what Maitreyi mentioned and Deepika also mentioned, whether this is the part of the COVID infection or the COVID-induced organ system damage related involvement. Kidney damage producing classical red half nail, we know, chronic renal failure. That is, I think, something to be, investigated and seen. And now there is no scope of further investigating it because we have already discussed that time we were very busy in managing such cases. Our pediatricians are very busy and we are very busy in giving them clue. But one thing is very apparent from what Prabhas said, as we all say, that skin is the mirror of internal system. He has very categorically mentioned that looking at the skin rash, he could gauge the severity of the COVID, which is extremely important. So I think there lies the importance of such seminar, that looking at the skin, you can understand to a great extent the severity of the overall disease and the response to treatment. I think here is the role of the dermatologist, particularly in this sector, pediatric dermatologist, for COVID rash in children and its prognostication, right? I shall come to Rashmi now. Rashmi, you are again from another state, Karnataka. You work in Bangalore, which is again one of the worst hit, COVID state. I am sure that in your hospital, in your center, which is a very well-recognized center in not only Bangalore, where enter Karnataka, you must have seen some children brought in the OPD with skin rash, and you have suspected COVID. And what type of experience you have got? If you could share with us.
Yes,
Over
sir.
to you, Rashmi. Yeah.
Yes, sir. Thank you, sir. So we have discussed a lot of skin rashes. How I differentiate these skin rashes in COVID-19 is I differentiate into two groups. One is skin infections, which we have seen in COVID-19 infections, and they have done the testing. They are RT-PCR positive. They are ready to do the test. Second group of patients are those who come with these kind of rashes, but they are not at all ready to get the testing done. So there is a lot more patients who might have had COVID-related skin lesions, but we do not know because they failed to do the testing. So during the second wave, as Deepika ma'am had rightly said, during the first wave, we did not see so many cases with skin lesions and all. As far as I remember, the most of my family members or friends or patients, they mostly used to complain of pruritus mainly during the first wave, post-COVID. Now, during the second wave, the most common skin lesion that we came across was urticaria. So there were patients who got RT-PCR done. They had children who had very mild fever, mild cold. So the parents used to think that is because of seasonal cold. And after doing RT-PCR, it became COVID positive. The other group of patients, they had family of COVID, and the child developed urticaria, but they failed to do the testing in the child. So we really don't know whether it was because of COVID or it was because of some other reason. Other cases, two cases I have seen of pityriasis rosea-like lesions post-COVID. Yeah. So the child had developed PR-like lesions around 1 to 2 weeks after the fever developed. And it was there for around 3 months or so, and now the child is completely fine. Then we have also seen cases of leukonychia. One case I have seen a single nail, which was completely white. And that occurred, though not during COVID, but it occurred around 2 months post-COVID infection. I have not seen any chilblain-like lesions or any vasculitic lesions in the child patients who come to our OP. They are more commonly in inpatient children. We don't have inpatient here. So most commonly is urticaria, maculopapular rashes, then pityriasis rosea-like lesions we have seen.
Okay, thank you, Rashmi. Thank you very much for sharing your experience. That is extremely valuable for all of us. I shall come to the next, set of, discussion, next part of the discussion. First with Maitreyi. I have given you enough time to rest after a wonderful talk. Maitreyi, the case in which you shared with us, that COVID case in a child from some hospital by Dr. Vikrant Prusti, I found that the child had subconjunctival hemorrhage as well as jaundice also, because conjunctival was, conjunctivae were totally yellow. Is that true? The child had jaundice also?
I talked with the pediatrician, and he said that it was basically looking muddy conjunctiva. Maybe in the photograph it was yellow because his LFT was completely normal.
Okay.
So, sir, maybe the photograph which was taken with the, sir, that is the difference between dermatologists and pediatricians. They are not much focused into photography.
So that is how you accuse your husband. Dr.
Sir, actually,
Maitreyi's husband, Dr. Mrityunjay, is a brilliant pediatrician. I know him personally. Yes,
actually, that patient was my husband's, and he got him admitted in the hospital, and Dr. Vikrant was taking care of the patient.
And you always win. Here it is in our favor that in a battle in the family between husband and wife always wins. So this was
True
good
for every family, sir.
That is good that you are a dermatologist and your husband was a pediatrician. No, what I am now, from a lighter vein to serious note, now the second thing which Deepika very nicely pointed out, that one is, and Prabhas also mentioned very categorically, that one is COVID, during acute COVID infection, the kind of rash, and the post-COVID complications on skin, what we have been seeing now day in and day out. So what is your experience? Because a lot of patients are coming. We know that, touch wood, let us see what happens to third wave. Probably it is not going to hit, probably, as per the, experts' opinion. But we have been seeing a lot of, we don't see, active COVID cases that much in any cities in the country currently. But a lot of complications of COVID, post-COVID, whether it is skin rash or whether it is, as Rashmi said, erythema, pityriasis rosea-like rash, hair fall, very common in nowadays. I think most of the cases of, hair loss of acute onset, of few months onset, you take a history, they will say they had very bad COVID. So what is your take on that, Moitri?
Yes, sir. The hair loss, what I see is among the youngsters, sir. Pediatric patient, I have not seen much with telogen effluvium. And sir, for pediatric patients, as Dr. Rashmi pointed out, I have seen pityriasis rosea, but I have not taken photographs, so I didn't put it in my presentation. And sir, also one more thing is, few of the patient complained of burning scalp, and there was burning skin. So one or two patient who had a severe course in the COVID was admitted in pediatric COVID hospital, and later on came for a skin consultation with the child's parents had come, and the child was complaining of burning skin and burning scalp. So sir, that again, I'm not very sure about the pathophysiology, but that is one unique presentation I saw in one patient. And others, sir, I would agree with Dr. Rashmi and other panelists.
Thank you, Maitri. Deepika, you have not come for quite some time. Yes,
actually, Maitri, it's interesting you said it, because actually trichodynia has been reported in COVID, so it was significant. So that is why, it's an interesting finding, because you don't see it. Here, I found what Dr. Prabha said very interesting. Now, what we have to remember is, because supposedly children have milder infection, he's the pediatrician, but they say that if you do a chest x-ray, many of the asymptomatic have chest x-ray findings. It's just that with children, because they are not overtly symptomatic, they are not brought to the healthcare. And, the proportion of admission is 1/10. So about 2% need admission and 20%. So we may not be seeing the rash in children. We may be missing because they're at home. And what Dr. Prabha said is very true. In our skin, for example, maculopapular sometimes is not very obvious. So we may have missed it also. Secondly, it is localized. Now, what is very fascinating about COVID is, many times the rash is not the diffuse rash that you see with other viral. You may have very restricted. We've seen limited to the neck and face. So, it's easy for the parent to miss, and because we know it disappears spontaneously, the more severe looking rash, for example, the COVID toes have a good prognosis, and the more localized acral ischemia have bad. And what you asked, it is very nicely linked to the pathogenesis. So actually, like any viral, most of what we see is linked to the pathogenesis, and it can be seen in multiple. That's the problem. 10 has been described. Like if we talk about the maculopapular, the clue is you can have in the same patient, you will have maculopapular, vesicular, as well as some petechial. Even flexural petechiae has been reported. And in fact, I have one patient with flexural petechiae. Now, she talked about hair loss. So again, the good news is that because we had a wave in April and May, hair loss occurs 2 to 3 months later. So now we must be on the road to recovery. So that's also a good sign. Now, most of them, in fact, report auto revert. They say that our hair loss has stopped. I started getting those kind of feedbacks also, my hair loss has stopped. But what we have to remember in children, the problem would be that most of them were never documented to be corona. Because testing in children is very, very, very much lower. Even people with overt, I've seen with my own relatives, they refuse to get their children tested. there seems to be a kind of that there's no need. So even internationally, a presence of a family member is taken as a indirect evidence. Even if you talk about the pediatric inflammatory multisystem, if you don't have a documented test, because most of these manifestations, even when they did testing, it was negative. So that is also a very high incidence of negative results in the pediatric age group. So what we will face specifically if you're talking about children is that you will not have a documented corona. The only history that you need to ask is whether a family member had a documented corona. What we have seen, which I just like to share, because since we're talking about it, and I myself have had it, that you can have autoimmunity. Dr. Prabhas will say that he talked about an SLE patient. I was very interested to hear that because that's my area of interest. So we've recently seen 2 patients with a flare-up of LE. And again, they did not have a COVID history, but their parent had a history of fever, and the parent also never got COVID testing done. So that's something we are going to see more and more, because our documentation in India, and I think maybe even in the world, may not be the most optimum, but autoimmunity flare-up is also reported post-COVID. So transient ANA rise is also reported. So these are all because in children, we should look out for these things, because I'm seeing a spike. I don't know, he's a pediatric rheumatologist. I was seeing that a spike in pediatric LE. We are seeing right now in my ward, there are 2 pediatric LE.
Okay.
So that is just a very fascinating thing, which I really hope that all of us look out for, and it'll be interesting to see, because we are talking about post-sequelae. So in addition to hair loss, acne, like Maitreyi said, a lot of acne, a lot of folliculitis in adolescents because of their wearing the masks, and especially in the humid weather. So the incidence has gone up, and we will be use line, you also said, but that is now again resolved just like the hair. So we will be seeing tinea because steroids, they received steroids. So we saw a lot of tinea incognito and is flaring up. Now that is what we are dealing with currently, because they could not come to a healthcare. The case that he said, it's not just us. Right now in our hospital, I don't know what is with the fullest ward is surgery, because these are all people who got their surgeries deferred because of the lockdown.
Yes.
So that is why the first thought is of a surgical emergency, what he was describing, abdominal pain. And it's nice that he picked up the rash. Many of them would have been missed.
Excellent.
So we're seeing chronic diseases, psoriasis, worsening psoriasis, which Maitreyi also described. So because they were mismanaged, their therapy stopped. So those are all the consequences that we are seeing now of patients with flare-up because of therapy being stopped during the lockdown.
Thank you, Deepika, for again very important points being brought up. Now I will go to Resham. Resham, would you like to add further to post-COVID kind of skin rashes what you have been observing?
Yes, sir. So in the post-COVID era, we come across, like, if we have to divide it, one can see drug-induced rashes like HCQS. Post-HCQS, I've seen erythroderma, which has appeared. Steroids causing acneiform eruptions is something very common. Further, there is a paraviral phenomena which are activated. So basically, the difference between a paraviral phenomenon and the viral phenomenon is that in a paraviral phenomenon, it is actually because of the modulation of the immunity which occurs because of the infection of the virus. So as a part of the paraviral phenomena, I've seen, of course, pityriasis rosea, both classical as well as atypical cases of pityriasis rosea. Reactivation of varicella, reactivation of herpes, then even Guillain-Barré syndrome is one thing which has also been reported as well as seen. And there was one case of eruptive pseudoangiomatosis, which was the classic presentation was multiple cherry angioma-like lesions with a peri-lesional halo. So that was one case. Apart from that, of course, telogen effluvium, tons of these patients we have seen day in and day out. Also, a few patients had this exfoliation, just palmar and plantar exfoliation. This kind of exfoliation has also been reported post Zika virus and dengue viruses, but usually it's a part of that toxemia which happens as a result of the viral illness. But in these situations, the exfoliation is in sheets, like large sheets. But in the two cases that we saw, the exfoliation was very fine. It was like psoriasiform in one patient, and it was self-limiting. Further, I've seen one case, but not in the pediatric age group, but prothrombotic phenomena which can occur post-COVID, as a result of which there were acral cyanotic lesions on the palms, and that patient had to be given anticoagulants, and also post-COVID, we also see certain drug eruptions due to these rivaroxaban, and yeah, so that was one thing that we saw. Apart from that, the regular things.
Thank you, Resham. Very important points you have brought up. I'll come to Prabhas now with the same question. Prabhas, would you just switch on your camera? And would you like to say us something about post-COVID patients who were coming for other systemic symptoms, and you take a history and get a history of COVID, they suffered from COVID, and any type of skin rash particularly you are seeing?
No, as such, not like that. But the incidence of sudden loss of hair after a severe MSC was common. It's not that much uncommon, and not any much. One or two rheumatological patients that presented with a flare of the diseases, but they had a history of fever 4 weeks or 6 weeks ago, not tested for COVID. I do not know whether these cases were positive for COVID or not.
Okay, thank you.
And only about the MSC patients that presented with a follow-up with discolorations, and sometimes some of them presented with a diffuse discoloration of the all over the body, scarlatiform rashes like that. No other typical features in pediatric patients.
Thank you, Prabhas. In the meantime, if anybody has any question, I hope it was understood that from the beginning, the way I always conduct. Anybody has any question or any clarification, feel free to put it in the chat box. I shall come to Rashmi. Rashmi, in the post-COVID period, what type of experience you have with the children?
So related to per se skin lesions specifically, I have not seen much of post-COVID skin rashes. Most commonly, yes, telogen effluvium, as we see in all kind of illnesses, be it any kind of viral illnesses, dengue, chikungunya, we see a lot of hair loss post that. So the same thing we had seen. One thing which was very striking that we saw, but I would say it was more common in adults than pediatric cases, was, as ma'am had told regarding psoriasis, the same thing I saw with vitiligo. We have seen quite a number of patients for whom the vitiligo, which was stable, it was okay, they were not getting new patches. Post-COVID, they started getting new patches. It was not because of stopping the therapy though. They were continuing the therapy, they were applying the medications, but post the COVID infection, a lot of patients are coming with increasing new patches. Also, surprisingly, we saw one case, it was an adult. So she had vitiligo, which was not responding to any treatment since quite a long time. And she started noticing repigmentation on her patches. So that was very striking. So that one case we saw. Otherwise, apart from pruritus and hair loss, and that one leukonychia case, which I have already mentioned, I have not seen very specific skin lesions post-COVID.
Okay, thank you, Rashmi. I think you again brought about something very interesting. What we call as a reverse Kovner phenomena. The same kind of thing can happen because of several inciting agents, several inciting preceding infections or trauma or insult. probably COVID in a way does sometimes some good also. And probably repigmentation of vitiligo is probably one. I think we should always take things with a lot of positivity. I think we have come more or less to the end of our, today's webinar. Just I think 1 minute left. I shall take this, the opportunity to sincerely thank Dr. Maitri Panda, our speaker for tonight, for the wonderful deliberation. And I sincerely thank all the erudite panelists for giving excellent input. Dr. Deepika Pandey, wonderful input, and thank you very much. And Dr. Resham Vasani, wonderful, input, very practical. Dr. Prabhas, you gave us, the story on the other side of the river, something which we always need to learn from you. And I am sure that we learned tonight. Thank you very much, Prabhas. And,
Thank you,
and thank you very much, Rashmi, for your experience in a very practical manner, because you are into pediatric dermatology mostly, and what you have seen, you expressed it in your own language, own terms. Thank you very much. This was a wonderful webinar. I'm sure all of you will agree with me. Finally, I thank our Institute of Child Health, our director, and the entire Institute of Child Health faculties for continuously working hand in hand together for difficult cases, particularly for cases of COVID, which need multidisciplinary approach, a team effort. And I sincerely thank our sponsor, Dr. Reddy's Lab, Grandera Division, under the leadership of Mr. Devobrato. And last but not the least, our technical support. It is not a team, it is a one-man army, Mr. Somnath Mukherjee. Thank you very much, Somnath. So this is just 10 o'clock. We are dot on time. Thank you very much. Thank you, everybody. And thanks for joining. We'll see you again sometimes, maybe. Okay.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Thank you, sir. Thank
Good
you
night.
very much.
Thank you. Bye.